So good morning, everyone. Cataract surgeons across the globe have agreed that when a patient undergoing cataract surgery has significant and regular corneal astigmatism, then the best way to treat it would be to advise a toric lens, and that is perhaps the most effective and predictable option that we have today to achieve emmetropia. Given that the incidence of treatable corneal astigmatism can be as high as 20 to 40% in our cataract population, the use of toric lenses have become more of a norm than an exception. And yet today we come across situations where we are not very sure whether suggesting a toric lens to this particular eye would be a right choice or not. So today I'm going to share with you some of such patient experiences that we have learned a lot from. The first patient I share with you was this middle-aged lady who came to us with a complaint of blurred vision in both her eyes and having undergone one eye cataract surgery elsewhere about a year ago. On refraction, we found that she had a significantly high astigmatic error left behind in that eye. However, it was this notch in the pupil that made me a little suspicious as to what was exactly going on. On dilatation, we found that there was a posterior capsule dehiscence. The lens was in the sulcus, but very importantly and surprisingly, it was a toric lens in a sulcus. So we have a decentered toric lens in the sulcus in the previously operated eye. This is the other eye that we were planning to operate, and what I'm showing you is the aberrometry image of that eye. In my presentation today, I will be sharing with you a lot of these aberrometry images taken on iTrace workstation, because this tool perhaps is the only place, although by assumption I can actually demonstrate the performance of a lens inside the eye. So for those who are not very familiar, these are the corneal aberrations in the lower left corner, and what this patient has is significant corneal astigmatism which is regular and treatable. Here what we have is the total eye aberrations, everything stemming from this eye, and what the machine does, what iTrace does, is it concludes that whatever that did not stem from the cornea must be coming from the internal part of the eye. And for all intents and purposes, the internal aberrations mainly stem from the lens. So because it's a cataractous lens, we have all these bizarre red and blue bars. With this patient having significant residual refractive error in one eye and a treatable corneal astigmatism in the other eye, the dilemma is, what do we do? Do we suggest a monofocal lens? Should we ask her to wear glasses for far and near in both her eyes? Or should we try and reach emmetropia in the second eye with the hope that we can reduce her dependence on glass? We followed the second option. We advised a toric lens. Following that eye uneventful surgery and toric lens in the bag, I am now showing you a post-operative aberrometry image where we hope that the internal aberrations are actually coming from the lens, which is a toric lens. So as you can see here, this is the corneal astigmatism that is being compensated completely by the toric lens inside the eye. As a result, there is absolutely zero astigmatic error left behind. But when you actually see her visual performance, this kind of a visual performance would definitely lead to a happy patient and a binocular unaided vision that would be less dependent on glass. So actually the lesson learned is that even if the previously operated eye has a significant residual refractive error, we may want to treat as much error as possible in the second eye. If it has astigmatism, then treat it with a toric lens, because that will significantly reduce the patient's dependence on glass. But a very important another lesson is that the toric lenses are meant to be implanted in the capsular bag in a well-centered manner. So if for any reason, if the capsular bag is compromised and we are not sure whether we can leave it behind in the bag exactly in the axis that it was meant to be, then it would be wiser to abort the plan for toric lens and implant a monofocal lens instead. A decentered toric lens will not only fail to do the job that it was supposed to do, but it would induce more astigmatism and other higher order aberrations that would significantly reduce the patient's quality of vision. So we always want to aim at leaving behind the toric lens well centered in the bag. The second patient is a farmer, a one-eyed person who came to us for his cataract in his left eye, but also had multiple corneal opacities. On slit lamp examination, we found that although he had almost nasal half worth of corneal opacities, the central cornea overlying the mesopic pupillary area was free from them. So we were quite hopeful that we should be able to give him a good visual outcome. On ocular parameter evaluation, we found he had a significantly high astigmatism to the tune of almost 4 diopters. But a very important thing here to ascertain would be the regularity. Given that he has a lot of corneal opacities, we want to make sure it is regular astigmatism. Fortunately for the patient, it was a completely regular corneal astigmatism, a typical bow tie in the central 4 millimeter area only. So we decided to go ahead and implant a toric. A T9 was implanted. And following that surgery, the patient was extremely happy with his unaided performance. So the more important lesson learned is that whenever we are associated corneal pathologies with cataract, we want to pay special attention to the cornea overlying the mesopic pupillary area, because that is the cornea patient is actually going to use for his sight. And if that cornea is free from pathology and has regular treatable corneal astigmatism, then and only then we want to advise a toric lens, which would definitely give rise to a beneficial outcome. Final patient for me would be the young female executive who came to us very, very unhappy. She complained of blurred vision in both her eyes and severe glare while driving at night. On asking, she told us that she underwent one eye cataract surgery a couple of years ago and had a multifocal lens implanted. Extremely unhappy following her cataract surgery, we on SLITLAM found that she actually did have a full diffractive multifocal lens, but the patient was categorical that I absolutely do not want another multifocal lens in my second eye, which is why I have come to you. Given all of her complaints, we were expecting that on aberrometry we'll find a lot of aberrations. Maybe the lens is decentered, maybe she has a very high angle kappa and alpha. To our complete surprise, there were absolutely no internal aberrations. The eye was completely suitable for a multifocal lens. She actually had significantly high corneal astigmatism to the tune of 2.25 diopters that was completely left behind uncorrected. So as you can see here again on aberrometry, this is the corneal astigmatism that was getting manifested into the total eye performance, and this patient actually required -2 diopters of cylindrical correction to get a good crisp 6/6 vision. To again show you the same thing in a visually simulated format, this is the blur caused by the astigmatism of her cornea, resulting in the total eye blur, which made this patient so unhappy, and she was not using any glasses whatsoever until now. When we evaluated the second eye that we were operating, we found that she had significant astigmatism in that eye also. And again, this eye also was suitable for a multifocal lens. But we had a dilemma. The patient was very clear that she absolutely did not want a lens that can possibly cause her any glare. She wanted to use computer throughout the day because of her kind of work. And although she accepted that she will have to use glasses while driving at night because of the glare problem, she was not exactly very keen on wearing glasses all day. With this kind of a profile, we suggested two options. We said we could either put a toric monofocal, but then you would need to use glasses while working on the computer, or you could go ahead with a multifocal toric lens with a low add power. Now this lens, we explained to her, would not only give her a good crisp vision for far and intermediate, which would help her work on the computer, but would additionally have a very remote chance of causing any glare. Following our confidence with it, she went ahead with that option of multifocal toric lens. Following this lens implantation, the patient extremely happy with her outcome in that eye. But let's take a look at the objective evaluation on eye trace again. Here is the corneal astigmatism, which is beautifully compensated by the toricity of the multifocal toric, giving the kind of visual outcome that we would want for all our patients. But again, very importantly is the binocular unaided performance. And with this kind of an outcome, the patient is not only less dependent on glasses, but extremely happy, and she will selectively use glasses when necessary. So the lesson is that just because somebody has a multifocal lens and is complaining of glare, it doesn't have to mean that it is arising from the multifocality design itself only. Very often, uncorrected corneal astigmatism will not only cause glare and blurred vision, but it can cause starburst kind of glare, which is extremely debilitating. So whenever we are suggesting a multifocal lens to a patient, we want to be very, very careful in our astigmatism evaluation and make sure that we are correcting as much of it as is possible. Finally, I would conclude and say that if we find that the lens and eye would actually benefit from a toric lens, and if we can ensure precision at every level of its execution, right from evaluation to surgery, then this particular IOL technology, the toric lenses, can be extremely rewarding in those who are suitable for it. Thank you so much.
Thank you, Lajja. And I think I just reiterate what Lajja said. The toric IOL correction is a necessity now, and we talk about the ametropic defocus, spherical defocus, but we do not pay attention to astigmatic defocus. So even 0.5 diopter of defocus astigmatism will be more lethal than a 0.5 spherical. So I think it should be a standard practice. We need to justify why we are not putting toric IOL. So I think this is very good, and thank you, Lajja. I have a question. before I learned all that, I used to have that if it is with the rule astigmatism, I correct differently, while it is against the rule, I correct differently. So could you clarify that, Shail? What is that with and against the rule philosophy?
Yes, I think what we need to keep in mind when we are doing a toric IOL, that we need to keep in mind the astigmatism that the patient is going to be left behind after the surgery. So it's not just the difference between the K1 and K2 that the patient starts off with. We need to add the factor of the surgically induced astigmatism as well as the posterior corneal astigmatism, which not most of our machines would give us as a direct value. So typically with age, the posterior cornea has an against the rule component to it. So if a patient, you are measuring with the rule astigmatism, that already existing posterior corneal astigmatism which is against the rule will reduce that with the rule astigmatism, which means you are actually overestimating what you are measuring for with the rule astigmatism, and vice versa, for against the rule you are actually underestimating what you are already measuring. So for many years there were nomograms like the Baylor nomogram, like the Abulafia-Koch nomograms, where you used to add that correction factor of 0.3 based on whether it is with the rule or against the rule. I think fortunately, thanks to Dr. Graham Barrett, most of the problems of toric IOL calculations have been taken care of. And his formula algorithm itself takes into account the posterior corneal astigmatism. So for now, people like me who get very confused with the rule, against the rule, vertical, horizontal, we don't need to be very conscious about that. The calculators take care of most of it.